Thanks to everyone. Our office is a couple blocks away from Duke Raleigh Hospital, and me and my partners are happy to take any phone calls, after hours, weekends, help triage patients. We often go to Duke Raleigh ER for consults or for patients who have problems. So hopefully we can help out the community. If you have questions, please let me know. This can be informal. If you can stop me and ask me to clarify, I'm happy to do that. So hand consultations are very common in the ER as well as urgent care. I think one study said that 10% of patients have a hand problem in the ER. So we do see a lot of these patients coming through the urgent care setting, and we'll talk about some anatomy and common conditions and when to refer to a hand surgeon. I like this tattoo of a patient of mine, pretty anatomically correct, and it made it easier to, assess the anatomic landmarks. Didn't even need an X-ray, just a good physical exam there. So, yeah, interesting.
That's an interesting tattoo.
So just an anatomy review. When people talk about which finger is injured, there can be confusion if you give the finger a number, like the second finger or the fourth digit. It can be a little confusing. So in documentation, what I use is basically use the name, such as thumb, index finger, middle finger, ring finger, small finger. There's less confusion if you just use the name. Some people call the middle finger the long finger. That's also acceptable. But everyone knows what the middle finger is. That's what I like to use. The small finger is also called the little finger, although sometimes when you're dictating, little can sound like middle. So those can get confused. So be careful on that. Hand surgeons also don't agree on the nomenclature. So, I stick to the names and I think it's easier. So tendons, flexor and extensor tendons, we talk about a lot. The hand is a high real estate area, a lot of nerves, tendons, blood vessels. Each finger has two tendons, FDS and FDP. The S stands for superficialis, the P stands for profundus. The thumb is just the single tendon, the FPL, the pollicis longus. And then the extensor tendons on the dorsum of the hand, you've got the EPL for the thumb and the EDC tendons for the fingers, the extensor digitorum communis. So the nerves, the sensory nerve pattern is listed here. So the median nerve is more on the palmar surface, involving the thumb, index, middle, and one half of the ring finger. So in your carpal tunnel patients, that's going to be the classic distribution. Your ulnar nerve is going to be the entire small finger, as well as half of the ring finger. And then your radial sensory nerve is going to be more of the dorsal radial, kind of that first dorsal web space area for your radial sensory nerve. Motor innervation, a good quick test. Say you have a child with an elbow injury and you want to check their motor function distally. Thumbs up, A-OK, and finger spread is a quick way to kind of check those motor functions. So thumbs up is radial nerve, extending the MP joint.
Like this.
Median nerve is going to be a A-OK, testing that thumb flexion and index flexion. And then finger spread, the ulnar nerve, checks for your adduction and abduction of the fingers for the intrinsic musculature. So timing, sorry for the gruesome picture. Yeah. So when do you want to see a hand surgeon? This is a hand emergency cases as soon as possible. Uncontrolled bleeding, compartment syndrome, ischemia, amputations, deep infections, abscesses, high pressure injection injuries, contaminated open fractures, and a dislocation that can't be reduced. Hopefully none of this comes into the urgent care, but something to be aware of. And the more common things that we see, these are, I would say, semi-elective, within 48, 72 hours. So it comes in on a Friday, it can wait till Monday, basically. These are most things: fractures, a dislocation that you can pop back in place, tendon, nerve lacerations, and a fingertip laceration that you can repair. We often like to see within a few days to assess the healing. And the reason for this is timing really matters for hand problems. If the patient shows up 3 or 4 weeks later, often we've missed an opportunity for a good repair on a tendon or a fracture or a nerve. So if we can get to them within a week, we often have a better outcome. That's the importance of the timing for a lot of these conditions. So we'll talk about some of the specific topics here. So subungual hematomas, we see them all the time. You all see them all the time. And often from a crushing injury, closed in a car door, etc. And there has been some controversy with this over time. These days, most of the time, we say you don't have to remove the nail. If the nail is intact, there's blood underneath the nail, just get an X-ray, look for a fracture. And if there's a lot of pain associated with this, say pressure underneath the nail, you can do trephination, which is basically burring holes in the nail. That is an option. That's only if the pain is severe and this is seen acutely. If patient shows up a few days later, there's no need to drill a hole in the nail. And if the pain is mild, no need to do trephination. This is a way you can do the trephination. Digital block is a nice way to do this. You can take an 18 gauge needle, clean the nail with alcohol, twist back and forth. You'll create a little hole, 1 to 3 holes to drain the blood. You can use a lighter with a paper clip to kind of burn a hole in the nail. I don't know which way is best. I feel like this is a way you can do it with a little more control. But doing a little cautery is also successful. Fingertip anatomy, it's a complicated part of the hand, part of the body. And you can see the nail is made up of both the germinal matrix and the sterile matrix. Germinal matrix is proximal. That's where most of the nail growth occurs, and that's deep to the eponychial fold or the cuticle. And then the sterile matrix is distal, and that's where a small portion of the nail grows from. The lunula is a half moon structure. It's that white color on the proximal aspect of the fingernail. Lunula is derived from the word lunar in I think Latin, I'm not sure, but that half moon shape is what gives it its name, lunula. You can see how close the nail is to the distal phalanx bone, and you can see where the flexor and extensor tendons insert on the bone, pretty close to that DIP joint. So common consultation we get is a nail bed injury often from a crush. And these patients come in often with either the nail disrupted or the nail missing, and with a laceration in the nail bed or the skin. So often there's a fracture related to this. Often these are open fractures. Different parts of the body, we worry about open fractures a little bit more. So obviously an open ankle fracture, open tibia fracture, these are really serious injuries, often go to the hospital, but open fracture in the distal phalanx is treated as an outpatient with wound care, much less likely to get osteomyelitis than open fractures in lower extremity. So digital block, a tourniquet can be helpful so that you can see the anatomy without as much blood. I recommend dissolvable stitches such as 5-0 or 6-0 chromic in the nail bed tissue. And I'll show you some pictures of that. So a simple digital block, this is a nice way to give a finger block with basically one stick. So you can put the needle right at the palmar digital crease. It only needs 2, maybe 3 cc's of lidocaine, and the whole finger goes numb, including the nail bed area. So it's only 1 stick. It's pretty simple, and it's very effective. So I was trained to use a dorsal intermetacarpal block, and you put it between the metacarpals, and it requires at least 2 sticks, if not 3. Sometimes the numbness is incomplete and it's painful. I found this to be a lot easier and simpler, as well as effective.
And I'd like to second that. Thank you. That's been life-changing and practice-changing. I've been using that since your last lecture, and it's just incredible. Very
great.
effective.
Awesome.
Yeah, thank you.
Yeah, thanks for that feedback. That's great. Finger tourniquets. Finger tourniquets are really helpful when you got a fingertip injury, because the fingertips bleed like crazy, and you can't see what's going on. So there's a bunch of ways you can do this. They sell things like these T-rings, tourniquets. We have tourniquets in our office. You can order them. They come in a couple different sizes. If you don't have those, you can do a cut glove where you just roll it down the finger, or you can use a Penrose drain and a hemostat. These are all options. I will say, it sounds silly, but you got to make sure you take the tourniquet off. You need some double check system, like a note to yourself or something, because it's easy to forget this and not remove it. And that's a pretty unhappy scenario, as you can imagine. Chromic, fantastic for kids, fantastic for nail beds. It usually dissolves in a few days. That's long enough to allow the tissues to reapproximate. That's all you need. You don't need nylon sutures in the nail bed. And it's actually nice because we don't have to remove them in the office. They just fall out when they're ready. So here's a patient who had a crush injury. Upper left, you can see the nail has been partially avulsed. You can see a laceration in the skin. So this one, the nail was kind of hanging on. Fracture was ruled out with negative x-rays. So I did this in the office with a digital block, a tourniquet, and I put sutures in the skin, and then only 1 stitch in the nail bed, put the nail back on, and eventually the nail fell off, and the new nail grew out. Most of the time, the nail is going to grow back. If you have enough nail bed tissue there, you will get some nail regenerate. And over the course of a few months, you can see the nail came back looking pretty nice. It takes about 3 to 6 months for the nail to regenerate to something that looks reasonable. So you can caution them about the long duration for nail regrowth there. Okay. Anyone have any questions about nail bed issues in injuries? We do hear these a lot, and you all see them frequently as well. All right, so I will say careful dressings. I've been in practice 12 years, and about every other year, I see a patient come in who's had a bandage on too tight, either at a primary care or ER or urgent care. And
oh my God.
Yeah. So I think the biggest culprit is either Coban that's put on too tight, or the tubey gauze, the gauze that's in the cylinder with the little cage. You put it on and you twist, and you put it on again, and that can constrict the finger. So these are all cases of ischemia from tight bandages. And some have led to necrosis and partial amputation. These two did, as obviously. These two here, actually, for as bad as it looked, all they needed was wound care and hand therapy, and the tissues remained viable. So these two patients got lucky from a long-term standpoint. Obviously, a lot of pain and difficulty for a few months, but in the end, did okay. These ended up with some partial amputations. Another common situation is when there's missing skin on the fingertip. So an avulsion injury where there's loss of skin and there's an open wound. So basically, we like to know whether there is exposed bone or not. So in the picture here, you can see there's kind of granulation tissue, there's an open wound, but you don't see really the bone sticking out. You can see the nail there. And so in this case, a simple bandage like Xeroform, gauze, and oral antibiotics is all you need after you clean the wound. And a lot of times we allow these to heal by secondary intention, as long as there's no exposed bone. So I'll show you some cases here. This case here, from previously, you can see loss of skin within the tactile pad or the fingerprint area. You can see that the nail is missing. There was no exposed bone, so this patient was treated non-surgically, just with bandage changes. Change the Xeroform once a day or every other day. Soak the finger in some warm water and some soap. Keep the finger moving with range of motion. And you can see how this regenerated. You can see the skin, a little bit of a contour deformity with scar. And you can see a little bit of contour irregularity on the nail. But functionally, this worked very well. Did not have any pain and did not need surgery for this. So it's a remarkable result, which we can see going from here to there. So this is when there's no exposed bone. Here's a case. This is a hand surgeon who accidentally cut his fingertip off. You can see cut a piece of the nail, skin, and he was meticulous. He took pictures of his finger every day for months, and he's got a website, and he shows the healing by secondary intention potential. So day 20, you can see a little eschar. Day 40, pretty much healed in. 1 year looks pretty normal. So this is just an amazing ability of the fingertip to heal itself. Here's some other cases where this required surgical intervention. This fingertip was still perfused, but kind of only hanging on. You can see the fracture of the distal phalanx here. This patient was taken to the OR, I think a day later, had suture repair, as well as pinning of the fracture, oral antibiotics, outpatient management once they had the hospital-based surgery. And then you can see the reasonable result here. Here's another patient. This patient here had loss of skin and subcutaneous tissue. He wanted the fingertip to look as normal as possible and wanted as much of that tactile pad and pulp restored. So we did what's called a cross finger flap. It's basically where you take skin from the adjacent finger, you cut it and you flap it over and you sew it to the defect and you let it heal in for 2 to 3 weeks. You come back later and you cut the skin bridge and separate the fingers. And then that flap of skin adheres to the wound and it has a pretty nice cosmetic result. You can see here. You can see on the ring finger where the defect came from. That was skin grafted on the top of the ring finger there. And you can see how the graft has taken on the small finger. So this is another option for fingertip injury that we will do. Here's just another case similar to the previous one of reduction, pinning, and repair. Another type of fingertip injury, this one was treated with an advancement flap where some skin is incised, advanced, and sutured into the defect, and there's a good result there. So, any questions so far about any of these cases or fingertip problems? Kids are amazing. I call them like the fingers like starfish in kids. So they're even more amazing how they can heal their injuries. Parents sometimes show up with a fingertip that's been cut off. In a young child, this can be sewn back in place. So in a child 5 or younger, you can take that fingertip, you can clean it, and you can sew it right in place. And amazingly, sometimes it will take and heal. It doesn't need a microscope or microvascular surgery for this to be successful. You do want to get an X-ray looking for what's called a Seymour fracture, which I'll mention. And if possible, use dissolvable sutures in kids so they don't have to be removed in the office, which makes it more traumatic during their recovery. The kids heal so quickly. In an older kid, if you sew the tip back on, it's still reasonable. Sometimes the fingertip will die, that tissue will turn black, but it serves as a biologic dressing and you eventually fall off. And usually there's granulation tissue underneath that necrotic cap. So it's kind of done its purpose. So it is reasonable to sew it back on if it's not too contaminated, and that's what the parents want. If it's a huge piece, like the whole finger, distal to the like DIP joint, it's not reasonable. But if we're talking mostly the skin and maybe a portion of the nail, it is reasonable. And it's amazing the number of people that come in with a piece of tissue in a bag who want it sewn back on. And sometimes it works in these cases. So this here, this is a fingertip injury in a child. It's hard to tell what's going on because there's blood. It looks kind of like a mallet finger. Once you clean it up and get an x-ray, you can tell it's more than just a mallet finger. This is a fracture through the growth plate or the physis, and this is an open wound. So what's happened is the physis is now contaminated. So it's an open fracture. And if that's not recognized, you can get an infection there. So this does require debridement and oral antibiotics. You can see here, this is where the growth plate is sticking out through the skin. So what was done here, this was washed out in the ER setting. It was reduced and splinted, and the nail bed was repaired. This is something that if it's not able to be done in the urgent care, it can be sent to the ER, or it can be sent to our office, and oftentimes we can handle it in our office. If the kid is really young and can't be done with local, we would take them to the OR, usually the next day, if possible. All right, so switching gears to phalangeal fractures. Any questions at this point, or are we okay? So a lot of finger fractures we treat non-surgically, depends on the fracture pattern, associated soft tissue injury. I will say if you're evaluating someone with a finger injury, it's probably best to get an x-ray of the finger rather than an x-ray of the hand, and I'll show you why. So this is a patient with a ring finger injury. This is a good PA view here on the right. Everything looks fine. The lateral view, you can't see what's going on. All the fingers are overlapped. You can't tell what's going on with that ring finger. So it's kind of an incomplete study when you get overlapping views with a hand film. Now, if you order just a finger, you would see this here. So this came in late, usually a few weeks later in our office, and you can see that there was a fracture at the PIP joint with subluxation. Acutely, this is more straightforward to handle. After a few weeks, this becomes a bear to get back in place and to achieve a perfect outcome. So this was a case that I saw that was missed just from the inadequate x-rays. So try to get a good lateral of that finger if it's injured. Also, take a look at the alignment of the fingers. If you look at the fingers with them straight, they don't look too bad in this case. You can see the spiral fracture, proximal phalanx. If you ask the patient to try to make a fist or bend their fingers, you'll see that in a spiral fracture, a lot of them will scissor. So that's a malrotated finger. We like to see these for fixation, usually within a few days, because this one won't heal well with it crooked like that. So rotational alignment is easier to check when the patient bends the fingers. There's various ways we fix these. We do pins. Sometimes we do small plate and screws or little screws. These are different options for fixation. Metacarpal fractures, often also very common injuries. This is a 4th and 5th metacarpal shaft fracture here. Similar to phalanges, we often treat stable fractures non-operatively Displaced fractures, we'll treat with surgery. These are plates and screws used in this case with a good result. Boxer's fractures, extremely common, probably the most common hand injury we see in an ambulatory setting. Often young men, alcohol related usually, punching something, a wall, someone's face, and you can see the fifth metacarpal neck fracture. Reduction, when do you reduce these? It is controversial. I would say the teaching 10 years ago was to reduce any of them that had more than 20 or 30 degrees of angulation. Now, a lot of hand surgeons are more conservative, and actually you can have a reasonable result without a reduction because there is compensatory motion at the CMC joint at the base of the fourth and fifth metacarpals. So even though you have an angulated fracture here, you can have excellent hand function long term. If you wanted to reduce these, this is a Joss maneuver. You can see here with a hematoma block, you can push up on the PIP joint and push down on the metacarpal, and that realigns the fifth metacarpal neck. You can place them into a splint, usually for 2 to 3 weeks, and then we start hand therapy. So this is something that we'll do for some patients who want to get that alignment restored. So on the left, this is a Boxer's fracture, classic. On the right, not a Boxer's fracture. This is a fourth and fifth metacarpal shaft fracture, much different treatment algorithm. There are some radiologists who will call almost every metacarpal fracture a Boxer's, but it's inaccurate to do so. So we'll switch gears, talk about the scaphoid. We talk about the scaphoid a lot, and everyone's always worried about the scaphoid when someone shows up with wrist pain after a fall. The problem is with the scaphoid, if it's fractured, it has a hard time healing because there's a poor blood supply to the scaphoid. So if it's neglected, like patients often do, they think it's a sprain, then it can go on to a non-union and wrist arthritis. So you have an 18-year-old patient with a scaphoid fracture, they ignore it. In a few years, it turns into a non-union and arthritis. Not a good situation for a young person to have arthritis in their wrist. We all get arthritis if we live long enough. If you're 80, you're 90, okay, you can handle arthritis. But if you're 30, you've got bad arthritis, that really limits your job potential and your hobbies significantly. So that's why we make a big deal about these. So oftentimes patient comes in, snuff box tenderness, base of the thumb. If it's tender, get an x-ray. If the x-ray is normal, that doesn't mean it's not a fracture. Sometimes a non-displaced fracture is hard to see at first. We would recommend telling that patient, you might have a fracture in your scaphoid because you're tender in your snuff box. Put them in a good splint, plaster, tell them to wear it full time, and see an orthopedist within a week or two, repeat the x-rays. Sometimes we get an MRI. If we're really convinced there's a fracture, that can be more sensitive than x-ray imaging. So this is the snuff box area, right in there. That's where it's tender in the scaphoid. You can see on the x-ray, you can see that fracture there. Oftentimes it's more subtle than that, but that's where a fracture of the scaphoid waist usually occurs. So a lot of times we can treat these with a few weeks of casting. It's usually about a 6 to 8 week course of casting. If it's a displaced fracture or unstable, then sometimes we'll fix these surgically. I won't talk too much about perilunate fracture dislocations. These show up in the ER rather than urgent care, but you can see the carpus bones all jumbled up. That's a very severe injury, usually related to a motorcycle or motor vehicle collision or fall from height. Usually needs to be treated urgently, go to the ER, go to the hospital. Normal x-rays of the wrist, you can see what's called Galula's lines. If you draw lines along the carpal bones, there are smooth arcs proximally as well as in the midcarpal and in the distal row. And so you want to look at that on this frontal view here, making sure the lines are all concentric. In a perilunate fracture dislocation, you look for those concentric lines, they're disrupted. So this PA view, something looks off. Lateral view, you can see the spilled teacup sign. So this lunate is tipped forward and there's no capitate within the lunate. So something's off. This is a perilunate dislocation. Go to the ER. Needs to be reduced and splinted or taken to the operating room that night if it's irreducible. Distal radius fractures, also very common. We're probably going to see more of distal radius fractures as people get more osteoporotic as they age and they maintain an active lifestyle. So trip and fall, very common in someone with osteoporosis to have a distal radius fracture. So here's a more mild fracture. You can see a intra-articular extension here going into the joint. You can see a fracture through the metaphysis here, and you can see an ulnar styloid fracture there. Lateral view, you see a little bit of a tilting of the joint surface. So this could be splinted. We're happy to see them in a day or two. We can talk to them about doing a reduction. Occasionally, we would do surgery for this in a high demand patient. This one here is a more moderately displaced fracture. You can see the fracture here as well as the translation on this lateral view, a shortening on the PA view, also ulnar styloid fracture. This one looks more unstable. This would probably benefit from surgery because it most likely will continue to displace based on how unstable it looks. Some more severe fracture, really bad translation. This piece here belongs right there. So it's completely broken off. This one probably needs a reduction that night in the ER. This is, Kim, do you all do reductions in urgent care setting of distal radius, or is that something more of an ER procedure, would you say?
I think generally ER.
Yeah, okay. I'll kind of skip this, but this is kind of how we would reduce them in the ER. We do this in our office occasionally as well with a hematoma block to stretch and reduce the fracture and put a splint on. And these splints, you know, are great, but if they're put on wrong, they can really cause pressure ulcers or stiffness. So when someone is splinting a distal radius fracture, we can keep the fingers free so that the fingers can move so they don't get too stiff. In the old days, orthopedists talked about using this cotton loader position because when you put the wrist in flexion, it helps realign the fracture. The problem is if you keep the wrist bent in flexion in a cast, it puts a lot of pressure on the median nerve and people get pretty bad carpal tunnel syndrome and swelling in their hands. So we don't recommend that splint position. The split here, this is a better splint where the wrist is more neutral and the fingers are free. So this is a good splint to be used in an urgent care setting for distal radius fracture. And then we fix these fractures, you know, semi-electively, usually within a week or 10 days. If there's significant displacement or if someone is active, physiologically healthy, we often fix these type of fractures. Okay, we'll switch gears to PIP dislocations. These are really common as well. It's important to know whether the dislocation is dorsal or volar. Dorsal is defined on where the middle phalanx goes, whether the middle phalanx goes dorsal to the proximal phalanx or volar. The dorsal dislocations are usually more simple, and they're often stable once you pop them back in place. These are the more common types. Volar, these are harder to get back in place. So you can numb them up, try to pop it back in. Sometimes there's a block to reduction, interposed soft tissues, or if you get it back in place, Sometimes it doesn't want to stay there. So it's good to let the surgeon know whether you think it was dorsal or volar based on the radiographs, because the volar ones we worry about more. In any case, you can splint them and refer to a orthopedist or a hand surgeon within a week. This is a good way to reduce them. It's tempting just to pull longitudinal traction on the finger, but doing so, you can interpose soft tissues just by pulling length. So this is a more elegant way of doing it. Basically, you're translating the bone at the middle phalanx here, and you're translating the proximal phalanx head there, and you're basically shifting them, and you feel a clunk, you'll feel a pop, and it's a satisfying reduction, goes back in place. And it's usually pretty stable once a dorsal dislocation goes back in place. We rarely have to do surgery for that. All right. Nerve lacerations, also very common. Numbness, tingling, electric shocks following the laceration is a nerve laceration until proven otherwise. So numbness in general is very common after an injury. A lot of times it's a contusion or a stretch injury, but when you have a sharp penetrating injury over the distribution of the nerve, and distally you have dysesthesias, pain, tingling, be suspicious for a nerve injury. You can do a few testing. You can do light touch sensation, just touching the fingertip, seeing if it's similar to the contralateral hand. You can do a 2-point discrimination with a paper clip, and which I'll show you how to do that. You can get a sharp, like a tip of a paper clip and scratch, see if they can feel sharp sensations. If there is a nerve injury or suspicion, we like to see these patients within a few days so that we can repair the nerve microsurgically. Earlier is better than late. This is 2-point discrimination. They make tools for this, which you can purchase. You can also get a paper clip, and you can get a ruler and put these tines about 5 millimeters apart. A normal hand should be able to feel these tines when they're 5 millimeters apart. And the farther apart they're put, the easier it is to feel it. So if someone has 2-point discrimination, they can feel those 2 points, most likely don't have a nerve injury. If they can only feel 1 point or they can't feel anything, that's more concerning. So this is a microscope we use in surgery. Sometimes we just use loops that are smaller magnification, and whereas more difficult nerves, we use this 10-time surgical magnification. We put small sutures through the epineurium of the nerve for reapproximation here. Funny picture, but common clinical scenario here. This is a patient with a laceration at the palmar digital crease. It's obvious they cut flexor tendons as you ask them to make a fist. So oftentimes the diagnosis is obvious from across the room, but in subtle cases where there's a partial laceration, it can be more difficult to figure this out. So you can test the FDS and FDP tendons independently, and I'll show you how to do that. First of all, the normal cascade of the hand. On the right, you can see how the fingers have this gentle curvature going from the index to the small finger. That's kind of what the hand normally looks like in its resting position. If you just hold your hand, relax, look at it, the fingers tend to curl like that. And you can examine a patient's hand from across the room and see if they have that normal resting cascade or posture. This patient here, you can see the index and middle fingers are sticking straight out. And you can see the laceration here in the forearm. So that makes the diagnosis more straightforward. To check the FDP and FDS, FDP flexes the DIP joint. So you check for isolated DIP flexion. You can block the DIP joint to see if that flexes when you ask the patient to move the finger. Checking the FDS you ask the patient to flex the PIP joint. And if you stabilize the adjacent two fingers, you can isolate that single FDS tendon to see if it's intact or not. Sometimes they have pain with this maneuver. That indicates a possible partial tendon laceration. If they can move it, but it's painful, you suspect partial tendon laceration. Extensor tendons will switch gears, dorsum of the hand. These are more superficial, and so you can often see this in the wound. Flexor tendon lacerations are deeper. It's harder to see the tendon from inspection. But extensor tendons, they're usually as you're repairing the skin, you can see if the tendon is cut or not. It's really helpful to us if you can tell us how much of the tendon is cut. Is it just a nick in the tendon, 10% or less, or is it a 90% laceration? That has some implications, because up to 60% partial extensor tendon lacerations can be treated non-surgically, just with splinting and without repair. So if you tell me that you saw the tendon was just 10% cut, a little nick, you repaired the skin, that could save the patient an operation, an exploration procedure. So we would treat that patient with therapy and splinting, and that usually will do well. Here's a case. You can see this laceration, dorsal to the MP joint. You're asking the patient to straighten the fingers. They can't. Obvious diagnosis. This is 100% laceration. You can make that diagnosis simply there. Just wash it, close the skin, and we'll fix this within a few days. These are some cases of extensor tendon repairs. This is at surgery with exploration. You can see some retraction of the tendon. It's pulled back out to length, and it's repaired with sutures here. And it does require a lot of therapy afterwards to get a good result like this. But this is something common that we do. Another type of extensor tendon injury is a mallet finger. So this is really common from striking the fingertip on a hard surface. I've even seen it, people tucking in bed sheets, reaching into a pocket, hitting it on the wall. These are all ways that you can get a mallet finger. And it's basically an injury of the terminal extensor tendon that ruptures. You want to get an x-ray to make sure there's not a fracture there. And these can be treated most of the time with non-surgical treatment with splinting. We usually do a good splint to keep the finger straight at the DIP joint for 6 to 8 weeks. And it's not one of these splints that the patient takes off and starts moving their hand, because as they flex their finger, those healing fibers break up. It's got to be 24/7 splinting. So I'll show you that. So this is called a stack splint. And a nice thing about this splint is it allows the PIP joint to be free. So it immobilizes only the DIP joint that's injured. If you don't have these available, or you're not comfortable with long-term treatment, we're happy to see folks. We have these in our office. We also have custom splints if the patient can't fit. Sometimes they're between sizes, they're in between, and it doesn't fit, or they're swollen. We can make custom splints for this purpose. But if the patient is compliant and they protect their finger, this can be a successful outcome with just splinting alone. Okay, just got a little bit more to talk about. Injection injuries. Has anyone seen this in coming through the urgent care? In a paint injection or grease injection?
Paint. Yes.
Yeah, it's a nightmare.
Also just a plain, well, paint is bad, and then just power wash water.
Yes. So any kind of solvent is going to be worse than water. Water is usually not that bad, but anything that's got a chemical in it can be terrible, because what happens is it penetrates deep in the tissues, and it causes toxicity around the nerves, the tendons, the blood vessels. So this patient came in, paint injection. You can see on the x-ray at the bottom that paint is delivered down the tendon sheath, even though the puncture wound was really distal. So this was explored, and you can see paint all over the finger. This can actually lead to amputation, especially if it's neglected by the patient. And it can cause necrosis, and the finger can die. So this requires debridement, sometimes a couple debridements, and the outcome is usually poor. But the earlier you get to it and the more extensive the debridement, the better. Hemorrhage, I won't talk about this. I will say, if this ever shows up in the urgent care, send it, and it looks like it can be replanted. Call Duke in Durham. They're the regional or replant center. WakeMed doesn't do them. UNC Rex doesn't do them. So you can clean off the area, put it in a saline soap gauze, put a bag around it, and then put that bag on ice. You don't want to put the part directly on ice because you can cause frostbite. So just clean it, wrap it up, send it on with the patient after notifying Duke. Sometimes they can't repair all of them, but at least have a conversation about it, whether it's an indication. I have a little bit about infections. I'm happy to talk about that because they are common. Does that sound good, Kimberly? Or
Yeah, I would love to hear something if, you know, and anybody can drop off who has to go for time constraints, but yeah, I would
Perfect.
appreciate that. We do see these a lot.
Okay, so I break these down into outpatient and inpatient management. So we treat these in the office and urgent care on the left: paronychia, felon, cellulitis, or a small superficial abscess. This can be treated locally, oral antibiotics. What's best treated in the hospital are things like flexor tenosynovitis, infection in the flexor sheath, a large abscess, a deep infection, septic arthritis, or ascending lymphangitis, progressive cellulitis. This is more IV antibiotics and surgical debridement in the OR. Paronychias, very common, infection around the cuticle, epinicial fold or nail fold, often in nail biters or manicures. It's basically cellulitis and an abscess right in this area. Sometimes people can get away with just soaking them with warm water, expressing the pus, oral antibiotics. If there is a pocket of pus that doesn't drain out, we want to decompress that. So you can use an 11 blade sliding against the nail to puncture it. You can have a little incision on the pointed fluctuant area. Basically, you want to get the pus out, culture it if you get enough pus. No need to suture it, let it heal by secondary intention. If there's a big wound, sometimes you can pack it with dressing changes. Most of the time, we're seeing more MRSA. So these days, most staph is resistant to Keflex, resistant to penicillin. So an alternative is doxycycline, clindamycin, or Bactrim. So doxycycline, Bactrim, clindamycin are oral antibiotics that usually treat MRSA. So those are often my first line when I see an abscess because MRSA is so common.
Would you do
Felon,
like a 10-day course, or how long a time?
good question. I think a 7-day course is reasonable if it doesn't look complicated. If you have someone immunosuppressed, you could consider 10-day course. But often 7 is sufficient. Felon is very similar. It's a fingertip infection involving the pulp or the tactile pad. So this is on the other side of the finger. It's usually very swollen, exquisitely tender. And if this isn't treated right, you can get progression into the bone for osteomyelitis or into the flexor tendon sheath to cause flexor tenosynovitis. With a digital block, you can make an incision along the lateral aspect of the finger, and it's just palmar to the distal phalanx. So you come in with your blade, and then you can take a hemostat or some iris scissors, and you incise these septations within the pulp, and you decompress the abscess by incising these septations. And If you get pus, it's good to culture it. You can pack it open with a wick, let it heal by secondary intention, and similar course of antibiotics, 7 to 10 days. I think the biggest mistake I see with these is a little tiny incision, like a 2 millimeter incision. Really, to decompress it, you need kind of a decent size incision, maybe a centimeter long. We're happy to see these. If you don't feel comfortable doing an IND, but we see these a lot. Often we do them in our office with a digital block.
Yeah, that one's out of my comfort zone for sure.
No, yeah, no problem. Yeah, there's digital nerves, vessels, so we can see these in the office for a IND.
Hey, I have a question. When you're coming in,
Yeah,
at that, are you coming in like parallel to the nail like this, or are you coming in perpendicular at the side?
yeah. I would say you're coming in, it's a longitudinal incision on the side of the finger. Yeah, not on the tip, but more on the side. Yeah. Good question. There's something called a fish mouth incision, and that's where you cut on the distal aspect of the fingertip, like around here, and so it looks like a fish's mouth. That doesn't heal very well, so I would stick to more of the lateral side for that. So a more serious condition is the flexor tenosynovitis. This usually starts from a puncture wound on the palmar surface of the finger. Patient comes in with their finger sticking out. They can't bend it. It hurts too much. If they try to straighten it, it hurts as well. So these are the Knavel signs. Sausage, swollen digit, tenderness along the flexor sheath going into the palm. The fingers in this partially flexed position. And if you try to straighten it, it's excruciating. They jump off the table. So this goes to the hospital. Needs to be drained out promptly, IV antibiotics, and surgery. Fight bite. This is from getting into a bar fight, hitting someone in the face. And what happens is you cut the MP joint with a tooth and you inoculate that tooth with oral flora. So this can result in septic arthritis, osteomyelitis. So I would say try to get an x-ray, see if there's a fracture or retained tooth. You can try to thoroughly IND it. Just leave the wound open. Best antibiotics for this is Augmentin because of the oral flora in humans. That's the better choice for this case. And oftentimes you don't see these patients early. You see them 2 or 3 days later. They're already got nasty infection developing. These you send to the ER. And this is a case, shows up. This was seen, was sutured. I think it was probably unrecognized that it was a fight bite, so it was closed tightly, trapped in bacteria. You can see it pussed out. And what happens is the tooth penetrates all the tissues with the finger's inflection. When the fingers are extended, you can't quite see the extent of the injury because the injury is no longer seen deep to the skin because it's in a different plane. So these can be missed because of that reason. High index of suspicion. If you see someone with a cut over their MP joint and they're giving you a shady story, it might be a fight bite. Bites to the hand, dogs, cats, humans, Pasteurella, Eikenella. Anyway, they're gram negatives, so you need something different than Keflex. So you should cover anaerobes, staph, mixed flora. Augmentin is the go-to. If you've got a true penicillin allergy, these are some alternatives. Clindamycin plus doxy, clindamycin plus Cipro, clindamycin plus Bactrim, Cipro plus Flagyl. These are all alternatives to Augmentin. And you usually need the plus because you want a double coverage, anaerobes, and the Pasteurella or Eikenella. So I always have to look this up every time, but I keep this written down somewhere I can refer to for those penicillin allergy patients. So that's it. So WebMD is something that makes a mild cold into a deadly disease that will kill you within the next 24 hours. So I'm happy to take any questions if anyone.
Yeah, real quickly, EpiPen injection into one of the digits.
Yes. Okay. Yes. So there is a reversal agent called phentolamine, and most of the ERs have that.
Okay.
So if the finger looks ischemic, it's white, it's pale, I would have them go to the ER for phentolamine injection for a reversal agent. Now, we use epinephrine in the fingers, but it's a much lower concentration. So when we use epinephrine for surgery, it's usually 1 to 100,000 lidocaine with epinephrine. EpiPen injections, I believe, is 1 to 1,000 epinephrine. So it's a much higher concentration. And there is a concern for prolonged ischemia and tissue necrosis. It's rare. There are cases where people get self-injected with epi, and it can live. But if it were my finger, I'd probably consider getting the phentolamine.
I've seen it a couple times in my career, and I do refer to the ER.
Yeah. Now, if it's in a thigh or dorsal hand or a place that's not as critical, obviously it doesn't matter. But if it's like volar surface of the finger, it can cause some ischemic changes. That's a good question.
Anybody else have any questions?
I have a question about like numbness after laceration in the finger.
Yes.
I'm never 100% sure, like if it's just related to the laceration and it will get back to normal, or like, I guess at
Right.
what point would be a good point to refer to you guys rather than just say, oh, it'll go back to normal?
Right. That's a good question. And I will say that even hand surgeons don't always know just from looking at the patient and talking to them. There are some cases where it's worrisome, and we actually go in and explore surgically, and we look at the nerve because you can't get a nerve study, you can't get an MRI that won't tell you the answer. Sometimes it's a matter of just looking at it with magnification, because your best opportunity for repairing a nerve is early on. Because if that nerve doesn't recover over a few weeks and it's been lacerated, then your chance of a good outcome with repair is much lower. So what I would say is if there is a laceration that's pretty deep and distally in that nerve distribution, it's insensate, I would tell the patient, I'm concerned about a nerve injury here. You should see a hand surgeon within a week. And if it has not made improvement during that week, then chances are it needs to be repaired. If it's making progress over that time frame and they're getting sensory function back, it's more likely a contusion or neuropraxia, which will recover. So if you give them a few days, less than a week, and you're seeing improvement, that's good. No improvement, that's more concerning.
Thank you.
Yeah, you're welcome. But that's a good question, and it's often it often comes up.
And I have a chat question from Dr. Christina Mendez. She says, for nail bed injuries where the nail is removed but cannot be replaced due to damage, what do you recommend as an alternative to protect the nail bed?
That's a good question. So if you're using Xeroform, you can use the foil from the Xeroform wrapper. You can take some scissors and just do a little arts and crafts, make a little nail out of the foil, and you can tuck that in there. That works nicely. And what you're doing is you're reducing the chance that there will be scar between the cuticle and the nail bed. So the epineuchial fold can sometimes stick to the nail bed and scar in and cause problems with nail growth. But if you stent it open with the nail or with a piece of foil, that can help the nail grow where it's supposed to grow.
And then have them follow up with you guys, or what's the follow-up on that then to remove the foil?
It usually falls off on its own. We would see them and we tell them to start washing their hand. And after a few days, usually about a week later, the nail will fall off spontaneously, unless it's sutured in place. If it's sutured in place, we'd cut the sutures and let it fall off. So yeah, we're happy to see them. We'll talk to them about it, but it only needs to be there in a few days. It doesn't need to be in there for weeks or months. It has done its job by that point.
Thank you.
Hey, Dr. Erickson, great lecture. Quick question, I just want to clarify a comment you made about scaphoid fractures and follow-up. Did you say we shouldn't put them in so let's say we have low suspicion, but we wanted them to follow up, make an appointment. Can we put them in a thumb spiker, a pre-made thumb spiker, or should we use some of our plaster, our 3M product? What's
So
best?
here's the dilemma. When someone gets a Velcro brace, in their mind, it's not a serious problem. They take the brace off and they go about their life. So that can be, and it's also not quite as rigid. A plaster splint that you mold or you put on and it's in place, that's going to signal to the patient, this is not something that I can take off, and it's more rigid. So that will encourage the patient to get follow-up for that problem and to not use that hand much, because what we typically see is young male basketball injury. They said, I went to the ER, went to the urgent care. They gave me a brace. I don't know. I didn't wear it. I'm now 2 months later. My wrist still hurts. It's getting worse. And so I said, I wish I saw you, 2 months ago.
Thank
Yes,
you.
good question. I think
Great
you can
question.
get away with a brace as long as you emphasize, hey, this could be, you really need follow-up for this. Yeah. Great question.
All right, anybody else have any questions?
And I would say you guys do a great job. I don't want to be overly critical here, because most of what we see is very appropriate. But I think these cases, these examples that I showed you are just ones that we can all achieve a better outcome with.